Welcome to ETSU Department of Psychiatry's Grand Rounds. The Grand Rounds Committee would like that everyone silence their cell phones and limit your electronic device usage during the presentation. Our presenter today is Dr. Jeff Forrest. I'd like to welcome my colleague, Dr. Forrest. He is a fourth-year senior resident who hails from the Washington, D.C. area. Dr. Forrest earned his BS in biology from Georgetown University and his MD degree from Virginia Commonwealth University School of Medicine in Richmond, Virginia. Dr. Forrest has also been an instructor for the Princeton Review and is an active and published contributor to Medscape Reference. Dr. Forrest will be lecturing today on psychiatry on standardized exams. Please welcome Dr. Forrest.
Good morning. Today I'm going to be talking about standardized exam construction and their function and analysis. It is noteworthy that I'm not going to be spending as much time today about actually doing multiple choice questions. That would be a different topic, although I'd be glad to present that at a later time. I should disclose that I have previously been employed, as Dr. McDevitt mentioned, by the Princeton Review. Any similarities to copyrighted materials during today's presentation are entirely coincidental. It is important to understand why it is we are doing what we're doing with regard to taking exams. Clinicians are required to recall, to analyze, and to implement a large quantity of information in a very rapid amount of time. To that end, exams are designed to determine which information is most important, which information should be used and when it is appropriate to act on that information and how, and when it is appropriate to not act at all. The core knowledge is one of the core competencies of medical education and ultimately has a major influence on clinical performance. Today's objectives with regard to standardized exam construction involve communication. Exams are intended to convey to examinees and to learners which information is most important. They are also intended to standardize experiences. We hope to present a consistent educational product with clerkship group to clerkship group, residency year to residency year. Though, of course, curriculum evolves over time, we want very much to provide the same educational experience to everyone in a given program, or near as can be managed. We also are fondly hopeful that exams will motivate studying and achievement by learners. Exams, unfortunately, do also have an assessment component. Clinicians desire to make inferences about learner skills, to ascertain the achievement of the core competencies, and to identify areas for further learning. Finally, there is also a quality assurance component. We wish to evaluate the achievement of above factors, whether it is in our Intro to Psychiatry course in the second year of med school, our psychiatry clerkship, our psychiatry residency training program, continuing medical education, or what have you. The methods by which we discern this involve a couple of methodologies. One is the content sampling, which information is being scrutinized and where and whether it's being done to an appropriate amount or with any bias. And also metrics. We desire to understand how, over time, the information is being conveyed, and there are ways in which we can measure this, which I will talk about in today's discussion. Content sampling scrutinizes whether the content of an exam is appropriate, whether we are communicating to learners what we need to communicate, the minimal objectives? And is there a reasonable representation of topics proportionate to the importance with minimum bias, achieving the aims that I have mentioned of standardizing an educational experience and also assessment? With regard to psychometrics, we desire for exams to be reliable. That is to say that if a person takes an exam 10 times, they get comparable scores on each administration, and there are no major splays in overall performance. We also seek to determine whether an exam is valid, which is to say whether an exam actually measures what it is intended to do so. The higher the stakes of an examination, the need for reliability and validity does increase. For example, the American Board of Psychiatry and Neurology presently features about 450 multiple choice questions in a span of 8 hours. The third-year medical school student shelf exam is about 100 multiple choice questions in 2 hours. Relative to the stakes of the exam, the need for psychometrics increases or decreases. With regard to format, presently the National Board of Medical Examiners recommends using a single best answer only wherever possible for purposes of standardized and standardization of data. Open-ended questions are left more to broad interpretation and could be scored in multifaceted ways. Most USMLE items are multiple choice of 5. There are exceptions, but this is the standard on the USMLE 1, 2, and 3, not the CS, of course. The stems must be closed. They must be focused, and they must be precise. Also, stems must avoid what are called technical item flaws. Technical item flaws artificially increase difficulty of an item for reasons not related to the subject matter at hand. Similarly, certain flaws make exam items too easy and also distort the overall validity of an exam. That is also called test wiseness. Certain stems contain extraneous information, though sometimes that is done on purpose. Questions or answers that are needlessly complicated may distort the overall validity of a test. It bears mentioning, however, that sometimes being able to sort through a large amount of information quickly and accurately is the intention of an exam. With such longer stems, reading skills are tested increasingly more, as well as just clinical reasoning. You may recall there is a verbal section on the medical college admissions test. It is in place for a reason. And again, sometimes the ability to sort large amounts of information is a portion of the topic under scrutiny. Things that may contribute to irrelevant difficulty include an inconsistent ordering of answer choices. Sometimes learners will not effectively read the answer choices or fall into patterns and not discern the intent of the exam author. Some of the students may have encountered questions where a bait and switch phenomena has been performed by an exam author. This would be an example of inconsistent ordering. Terminology that is vague may also contribute to difficulty not intended by an exam author or constructor. Also, none of the above. This answer is basically never used on National Board of Medical Examiner items anymore. It becomes problematic because it involves weighing infinite possibles. If you say none of the above, then you are opening the door to anything else being a potentially correct answer. This results in distortion of an exam's intent. Test wiseness flaws include grammatical cues. Sometimes, inadvertently, an exam author will write an exam item that tips his hand as towards his or her intent. It is also necessary for distractors, or incorrect answer choices, to be plausible. Also, distractor choices may not be mutually exclusive or exhaustive. Wrong answers that rule each other out will tip on a savvy exam taker whether they are completely understanding the exam topic at hand or not. Take, for example, absolute terms. Distractors that are more absolute, always or never, very rarely used by the National Board of Medical Examiners for that reason. Again, it opens up a language of potentially infinite challenges and is avoided. When answer choices are inconsistent in length, this may also cue the savvy test taker. Therefore, the board recommends keeping distractor lengths as close to each other in length as is possible. Take, for example, this algebra problem from my days in the Princeton Review. The actual content of this question isn't really all that germane to our discussion. It's an algebraic nightmare and doesn't really have anything to do with psychiatry. However, I have included it for one important reason, and that is, if you examine these answer choices, they look consistent, and there's basically no way, without doing all of the complicated math that may be entailed, to answer this question correct. If, by contrast, I change the answer choices to this, I'm going to wager most of you would answer this question correctly without a paper or pencil, unless you round up an awful lot. In analyzing the performance of items in multiple choice format, there are 4 areas of concern. How difficult an item is, very simply, the number of people that get an item correct compared to the number of people that do not. Item discrimination, which is somewhat different. That measures how well individuals that tend to do exceptionally well on a test tend to do on an item compared to individuals that are not doing very well on the same assessment. That can be measured in a number of different ways. I will demonstrate examples in a few moments. The item options must also be assessed. Are some distractors too tempting? Are some distractors incorrect? Are they not plausible? And there's also a comparative group analysis. How do different groups perform on the same test item? Suppose you change the level of performer. Med students, attendings, residents, non-medical personnel. How big is the difference when you change a variable that may result in differences in performance on an item? Again, item difficulty, very simply, the percentage of people that answer an item correct. The higher the percent, technically the easier the item. It's fairly intuitive that items that are too easy or too hard do not really inform the examiners of much of anything. Getting above 95% doesn't really tell us much, and neither does having less than 30% of a body of learners achieve. You would expect on a multiple choice of 20% to get just from random guessing or doing letter of the day. Noted that the difficulty ratings will change if you change a variable related to the population that is being examined. In theory, more experienced residents will perform better on a psychiatry item than less experienced residents, which in turn would theoretically generally outperform students, who in exchange would also generally tend to perform individuals with no medical education whatsoever. A goal is to have a range of difficulties that allow us to separate out relative good performance in a normal distribution like this. Most of you have seen the Gaussian standard curve. Very simply, down here you have distance in terms of standard deviations. It is expected on exams that have a certain assessment component that there will be some exceptional performers and some that are not exceptional performers. But most ranges of scores should be something in the relative middle. With regard to item discrimination, again, we are asking whether an item really separates out high achievement from low. That can be measured in a number of different ways, but the simplest is to take the top, say, 27 or 33% of achievers on a certain item and compare the bottom 27 to 33% of individuals assessed in the same exam and obtain a ratio. High discrimination indices suggest that examinees that tend to do well on a test overall do well on a given item. If, however, there is a zero correlation, the item is relatively unpredictive of whether an individual tends to do well on a test or not. That can be due to a wide variety of reasons. It unfortunately also does happen where there are negative discrimination indices, where individuals who have done more poorly on an exam in general are doing better on a given item. That can be for a variety of reasons. Perhaps there was something miscued in a syllabus somewhere, perhaps a lecturer misspoke, or perhaps the exam item is just incorrect. All of those things may happen. Hence the need for these metrics to ascertain the relative quality of an educational construct. I also mentioned item option analysis. In test-taking lingo, the key is the correct answer choice of the 5 of which we are scrutinizing, and distractors is the term for incorrect answers. How plausible are the distractors? If they're not plausible at all, there's effectively a higher percentage chance that an examinee will guess the correct answer by random. If an option is not chosen at all, it suggests that it probably isn't a very good distractor. Not fooling anybody. However, if an option is chosen too frequently, it prompts an investigation to find out why, such as some of the factors that I mentioned before. Perhaps something is written incorrectly in a syllabus. Perhaps the exam itself is written correctly, but the answer choices were not, or there was a miskey. All of those things can potentially result in distortions of these metrics. It is also essential in assessing exams to perform a comparative group analysis, if available. Comparing performance on an item by different groups, especially ones of different educational levels or different times, may be indicative of potential information that is helpful to the administrators of an exam. You can assess, for example, how one clerkship group performs on an item compared to another. And I have, and we'll demonstrate this in a few moments. And again, you can also change the educational level, how M3 students do on a test compared to PGY1s or PG3s or attendings or non-medical personnel. Another item under scrutiny in constructing exams is choosing the target topics. Knowledge-based exams, such as the USMLE Step 2 CK, Step 3, Step 1, prioritize the core competencies of medical knowledge and patient care. Other competencies, such as interpersonal skills or professionalism, may also be tested but appear in much greater focus on exams such as the United States Medical Licensure USMLE Step 2 CS. Today we are focusing on knowledge-based exams. Clinical medicine exams focus on numerous topics with regard to medical knowledge, including the recognition and recall of essential facts, diagnosis tasks, including deciding what history or physical lab studies to obtain, how to formulate an appropriate diagnosis, how to understand where we are in the workup of a given complaint that presents in clinic or in the emergency room or on the floor. Management tasks include choosing appropriate pharmacotherapies, health maintenance, prevention strategies, clinical interventions, mixed management, or surveillance for disease recurrence. It is essential that learners recognize emergency situations. The NBME has a particular predilection for selecting topics wherein it is essential to recognize information or there is great potential for serious problems or mayhem. It is also essential for the board to understand that learners know when an intervention is necessary, or when minimal or no intervention is most appropriate. I mentioned before that none of the above is generally not used on National Board of Medical Examiner items. However, item choices like reassurance or no management indicated at this time are sometimes used because those are closed, as opposed to the open-ended none of the above. I've included this directly from the National Board of Medical Examiners website. This is just an example how the USMLE Step 2 CK prioritizes tasks and topics. The medical knowledge and scientific concepts component, for example, is much lower than the USMLE Step 1. And it's still higher than the USMLE Step 3. Instead, there's a much greater emphasis on diagnostic tasks and management-oriented tasks, like I discussed previously. History, labs, knowing outcomes, choosing appropriate therapies. These are the tasks that are predominantly under scrutiny on the shelf exam and on the USMLE Step 2 CK. There are also, generally speaking, a few ethics, a few professionalism items, some system-based items thrown in. But those are not emphasized on the USMLE Step 2 CK. Without getting bogged into the details, this is just an example. Different exams, of course, have different relative priorities. I will now present a series of 5 multiple choice items of my own authoring that have been employed in the last several months in the M3 clerkship here with the Quillen College of Medicine in order to illustrate some of the discussion points I have mentioned. In this situation, you have a 26-year-old female, history of depression, psychotic features, that comes in very flushed, diaphoretic, has myoclonus, has a very high temperature, has a noteworthy array of meds. Without getting too bogged into the details, I'll point out that the intent of this question was to discern a couple of things. One, that the learner can recognize and perform a differential diagnosis of MAOI toxicity versus neuroleptic malignant syndrome versus serotonin syndrome, which is challenging to the uninitiated or even the initiated, and then also recognize that certain recreational drugs may cause serotonin syndrome. So I've added a few annotations here to tip off some of the buzzwords a savvy examiner may recognize: myoclonus, party, best explanation. But what would happen if I were to take that word party and change it to rave? Dead giveaway. I offered this item to a number of non-medical personnel, including my mother, my brother, a couple of non-medical friends of mine, and inevitably, individuals with no real medical knowledge are able to answer this question correctly if I were to commit this technical item flaw. The association between recreational drugs and raves is well known. So, even non-medical personnel were able, frequently, with that error, to answer the item correctly. However, in its pure form, with the word party used instead, I had clerkship groups 4 and 5 attempt the item. And you can see how relatively popular the other answer choices were, suggesting that, indeed, the differential is tricky and not at all easy to get correct in a one moment of study. I'll also point out the difficulty being about 30%, probably just on the razor's edge of what would be considered tolerable if the point of this item had been to be assessive. We do not include the questions from these Lunch and Learn projects in the clerkship grades. They are more intended to be instructive. So the fact that there are some difficult items is relatively less concerning in this situation. It is simply intended to educate the learner. However, it was clear that students that tended to do well on the project overall would tend to answer this question correctly, as you can see from the positive discrimination index. Withdrawal from medication was not selected at all, suggesting there may be a need for a more attractive distractor. Take this example. 56-year-old female with chronic schizophrenia. The intention of this question was very simple, again, to test a number of concepts. One is that the learner understands what the pathogenesis of extrapyramidal symptoms is. Many students will understand that blocking dopamine does have a role in generating EPS. However, not every learner remembers from their basic science classes that cholinergic activity increases when dopaminergic activity is blocked, and that the treatment for extrapyramidal symptoms actually may include anticholinergic agents such as benztropine, cogentin, or diphenhydramine, Benadryl. Note that there were really two answers religiously picked by students, erring at the location of the pathogenesis or simply not recognizing cholinergic activity being important. However, noted that there was actually no correlation between students that tended to do well versus those that did not. Now, this may be due, well, unfortunately, to my fault for committing a possible technical language flaw. The way these answer choices are written, I admit with some intent, was that students do have to read very carefully. A change in the pattern may inadvertently lead students off the path. That could be considered. However, there is not enough data to really make a, N was about 20, I believe, on this question. There isn't really enough data to conclude that for sure. I'm just pointing out that when you change, if you have, duck, 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 goose, duck, in your answer choices, it will tip a student off. This vignette was a little bit more complicated. It features a woman suffering from postpartum psychosis. There were a couple of, without wanting to get bogged down into the details of this item, I will highlight a few of the essential features and the answer choice. This was an example of an item where the intention was for the learner to recognize an emergent, severe situation. A patient that is attempting to strike herself in the abdomen is very concerning, as is the postpartum psychotic syndrome demonstrated by the severity of the symptoms in this vignette. Unfortunately, a substantive number of learners chose supportive care and reassurance, suggesting to the exam authors that it may be necessary to remind students to assess the overall severity of a situation before getting into the nitty-gritty of management choices. I also note a substantive number of students chose 4-point restraints, which I will mention for students is almost never the correct answer on the National Board of Medical Exams, USMLE series. Also, of course, We certainly hoped to communicate during the course of our clerkship that ECT is a very reasonable choice for an emergent or relatively severe psychotic syndrome, and that it's safe in postpartum. This item actually performed very well. About half of students answered it correctly, but students that did so tended to be overall more knowledgeable per our presumption. Again, it is an assumption that students that are doing well on our assessment are more knowledgeable, though our data are suggestive of this. This item is a little bit more simple. It features a routine major depressive syndrome in the vignette. Nothing really particularly doing. This vignette could actually probably be interchanged for a lot of different major depressive symptoms and is not that difficult just from reading it. However, not every student, and unfortunately not every resident, is aware of the fact that actually there is increased REM sleep in major depression, and that the time to REM sleep is generally decreased. This is an example of an item wherein learners tended to do well on the item for one important reason. This is knowledge that you're not very likely to get from clinical practice so much. This comes from reading. The better read students and residents tend to answer this item correctly. But it would be very possible to go through 3 psychiatry clerkships and never learn this particular fact. For that reason, the National Board of Medical Examiners loves to test it on the USMLE. It is an example of a great discriminatory item that is not disputable. That said, there may be a few problems with this particular item. Note how basically nobody chose any of answer choices C, D, or E. Look at the similarity between choice B and choice C. That might be considered to be, on my part, a technical language item flaw. All the same, I decided to leave this item as it was because it was performing very well in its intended methodology, and predominantly to help fill in the gaps of our clerkship. A central aim of these items was to help provide information that is not really being covered anyplace else. Finally, a dementia item. 71-year-old woman, forgetfulness, disengagement, recently widowed, poor effort on her Montreal cognitive exam. This item was intended to accomplish a couple of things. One, to make sure that learners understand that not all neurocognitive disorders are, strictly speaking, from neurocognitive dementive disorders. That dementia and mood disorders may contribute to a presentation of cognitive slowing. Also, that students and residents do not jump ahead in management. The correct answer choice here, performing a suicide risk assessment, is an essential feature of someone with a management of someone with a substantive mood presentation, and should be done before any therapeutics or further diagnostic workup is initiated. Understanding the order of operations is essential for a clinician to practice medicine effectively, and so the National Board of Medical Examiners is exceptionally fond of questions just like this. Again, you can see, though difficult, this item tended to separate out strong performers from relatively less strong performers. Finally, just to kind of share the results of one of my pet projects. As a result of these information of which I've presented, I have been presenting a series of 30 multiple choice questions in two 15-item sets to the medical school clerkship for the last 4 or 5 groups with the gracious mentoring of Dr. Raj Lawala and Dr. Martha Bird. And they've allowed me to participate in the clerkship, for which I'm very grateful. These are the national means for the psychiatry shelf exam and for our institutions last year. We used the first 2 groups, which did not have my questions as a control, and then compared overall average scores on the shelf to those that had. Generally speaking, students that had at least 30 multiple choice questions of our composition tended to do about 7 points better, close to a standard deviation better on their shelf exam. The intention of these questions, which I developed, was intent to help patch in some of the gaps, provide quality assurance to help make sure that we do teach some of the things that show up on the test but may not be encountered during a clinical clerkship. However, I do have to acknowledge that because these are more seasoned clerks, there may be some experience training effect from having had an extra clerkship or 2 before taking the psychiatry exam. Invariably, there will be an internal medicine item or 2 or a pediatrics item or crossover item or 2 on your psychiatry shelf. And students that have had those clerkships may potentially benefit. All the same, it was clear to us that there was a benefit to adding multiple choice questions, not so much as an assessment, but as a teaching and instructive tool with regard to achieving the aims of the National Board of Medical Exams. At this time, I would like to make a few acknowledgments to the faculty mentors for my Grand Rounds, Dr. Hendrick and Dr. Lawala. But in particular, Dr. Bird. I've written about 100 of these items now, with Dr. Bird being my predominant item reviewer. And we've had some very fun conversations about how to fix items, how to make them more tempting, how to make sure that they really do communicate. I've also been granted the opportunity to contribute a few questions to the second-year medical school exam, which a resident doesn't always get, so I'd like to express my gratitude. Also, Dr. McDevitt, McNamara, and Ikikwari have helped me review some of the items in their infancy. These things are an evolving process as we get data and feedback on questions. It isn't easy to write quality items. I've learned to my horror that it really does take several kicks at the can to get it right. Also, the students in groups 4 and 5 were very enthusiastic participants in my project. So, though I don't believe any of them are here for the record, I do want to acknowledge the participation of students. I wrote this project predominantly for you, and the more eager and enthusiastic your participation, the better I can make it for you, as well as anybody else that has humored me with these questions. And speaking of questions, I would be very glad at this time to field questions if you have any. Thank you very much.
Well, I just want to thank you. This is the first time in my lifetime I got some education regarding how they put the question together, because I came from a different country. In the past 18 years, I never knew what they are doing. I just took the test many times. But one thing that I noticed that you also mentioned, several of these tests, it depends to the mindset of the person who makes the test. For example, the test that you just said, what is the best next step? If someone's sitting in an ER, they do the mental health suicide risk assessment. They also draw the blood and they send it for the TSH.
Of course.
And as you see that some of those people that they were questioned, 47%, they choose the TSH and CBC in order to rule out and make a diagnosis on that situation.
Oh, yes. The National Board will have several other correct answers. However, there will always be one answer, and I tell you, from my understanding from people that I know that have contributed to writing, for example, the USMLE, they flash a candidate question up on a screen like this in front of an entire room of individuals that are seasoned attendings in the discipline of scrutiny, and they all have to come to the same correct answer. Otherwise, and of course they do statistical analyses like I've done and either discount or, like if for some reason there is a significant deviance from what is intended, there is a certain amount of philosophizing, agreed. However, much seems to depend upon the relative importance. For example, your point is extremely well taken with regard to a suicide risk assessment. The National Board wants medical school students to be thinking about that. They want to make sure that at all costs that has been done, because if that is not done, there is a clear violation of the standard of care. So there's a certain amount of, and you're right, different authors will have different relative biases.
Yep.
The process becomes standardized for this reason.
The reason I brought that one up is mainly because they said, what is the next step? It's not the most important evaluation, for example, that you have to do. And when they say, and I have seen plenty of these tests that has the next step, because they are putting it step by step and not the most important things before you send the patient home. That's a perform of the suicide risk assessment. Sometimes we keep the patient in a system for several hours in order to do all this evaluation, and we don't send them home without doing the suicide risk assessment. But this is only one example. And the second things that I was concerned about is when we do have this normal distribution, we are also putting at least a group of the people, means that we are expecting some people to fail. And
of course, depending upon the intention of an exam, this may not be what happens. It may not be the intention for this to be what happens. This was demonstrated simply as an example. One, in our Lunch and Learn, actually this is pretty close to how the students do, but the intention wasn't to be assessive, it was to be instructive. So that's all the same, I do wish to speak to your point. It's very well taken. There invariably tends to be a substantive difference in exam world and what actually happens on the clinical, in the trenches. That is a very reasonable criticism, and of course the National Board of Medical Examiners may try to narrow that. These are simulations, nothing more, intended with the fond hope that when the pager goes off, a resident or student or what has it is thinking quickly and prioritizing tasks in a relatively important manner. It is entirely possible, of course, that subjected to greater numbers, higher N, some of these questions would prove to be unsuitable for reasons like what you mentioned. However, for purposes of actually instructing and conveying a point, they've borne out, at least so far, to be reasonable. Still, thank you very much for your commentary. It's essential.
So, Jeff, one of the things you didn't discuss was what about tests that are repeated year after year. And one strategy that's looked at in developing the assessment of the quality of tests like that is to use specific items in areas that have stable performance and are considered essential. So for that item itself, you want to document that the performance remains good across years. And it's also used to compare against all of the other questions in the area to try to assess that the appropriate breadth of the area is being represented. Just thought I would ask you to comment on that.
Absolutely. So a certain form of comparative group analysis, which I mentioned, would track that. Ultimately, I did find myself having to make some cuts if I was going to get this all done in 45 minutes. All the same, though, it is absolutely, I mean, perfectly reasonable. You saw the USMLE Step 2 CK breakdown I have. They are definitely going to measure how different diagnostic items did against others, how different dementia items, how different neuro items, how different mood disorder items compared, due to one another. And they also are very vigilant in making sure that there's no test author bias. Just because, say, somebody happens to be like, you're an expert on HIV, dementias, if that may be, someone might know as much as there is to know about that kind of thing and be unfortunately predilected to writing items on that topic as opposed to the entire sweep of neurocognitive disorders, which of course is exceptionally vast. So the NBME does have metrics. As you have pointed out, some of that stuff is probably closed file. They don't want zealous learners to be able to crack the code. These are closely guarded secrets. However, actually, a lot of the information that I presented today is available online if you just know where to look from the National Board of Medical Examiners Exam Constructing Manual. Sir?
That was exactly my question for the relatively naive test taker. So the thing to do, it is possible to go and look at what the philosophy that is being tested is. I mean, I agree with Dr. Hayel. There's a fair amount of bias in these questions sometimes. But, for instance, your order of operations question,
Yeah.
it's insightful when you think about it in terms of order of operations, but for the naive test taker that hasn't looked into this as much as you would suggest Googling that information at some point in time?
The National Board of Medical Examiners exam authoring manual, I found to be a very interesting read. I always advise students or learners of any level, really, to know your enemy. And that, I mean, Josh is laughing because he's a hunter, and the same philosophy applies. But you, I think, can gain a great deal of insight when you understand their intentions, because it's probably true there are inevitably a few examinees who really actually do have the knowledge, but do misunderstand the intention of an exam author. And it's not easy to tease out those biases. All of us are biased, of course we are. We've all come from different institutions, different fronts of training. Some of us are more research-oriented, some of us have spent more time in the clinic. The time we've spent in the clinic will vary, different residents, different programs, settings. The National Board has the unadmirable task of producing a product that is standardized. And the metrics are ultimately, like some of the ones I demonstrated today, really the only thing they can cling to at the end of the day. All the same, yes, I think looking at that manual, perfectly reasonable thing to do. I think they make you log in, but it doesn't, it's not, that part is not under lock and key. Actual exam materials, obviously, well, those have only limited availability.
Thank you, Dr. Forrest.
It's a real privilege. Thank you very much.